We can't keep stacking the cards against people and then blaming them for bad outcomes. How do you extend that from a systems approach to be thinking around how we better support people instead of chastising them or blaming them, which it totally does not line up in a positive way for better health outcomes.
Hi, everybody. Welcome to the Zero Hunger Project podcast. I'm your host, Suman Roy.
And I'm Stacey O'Neill.
And today we're going to talk about something that many of you are probably thinking in your mind: prescriptions for change, tackling hunger through health policy. And we have a very special person with us, Dr. Andrew Boozary. Stacey, do you want to talk a little bit about him?
I'm very happy to tell you a little bit more about Dr. Andrew Boozary. Is a primary care physician, health policy expert, and the founding executive director of the Gattuso Center for Social Medicine at the University Health Network in Toronto. His work focuses on integrating social determinants of health, such as housing, food security, and income, into healthcare delivery to address systemic inequities. Under his leadership, UHN has launched several initiatives aimed at improving health outcomes for marginalized populations. Notably, the FoodRx program is a collaborative effort with FoodShare Toronto that provides medically tailored food prescriptions to patients experiencing food insecurity. This initiative recognizes food as a fundamental component of healthcare, aiming to improve nutrition and overall health outcomes for vulnerable individuals. Additionally, Dr. Boozary has been instrumental in the development of Dunn House, Canada's first hospital-led supportive housing project. This initiative offers affordable housing with integrated healthcare services to patients who are unhoused and frequently utilize emergency services, addressing the intersection of housing and health. Dr. Boozary's approach emphasizes the need for healthcare systems to move beyond traditional clinical care and address the broader social factors that influence health. His work advocates for policy changes that recognize and act upon the intrinsic link between social conditions and health outcomes. Thank you for joining us today.
Thanks so much for having me.
Dr. Boozary, I'm going to jump right into something that I've heard you speak about before, but would love our audience to hear this. You have co-authored the CMAG article where you describe social admissions to hospitals as policy failure. How can healthcare systems shift their approach to address the root causes of food insecurity as part of the patient care?
Yeah, thank you. And thank you again for the invite and all the amazing work that you're doing to bring these conversations to the forefront. And I think when we're talking about the hospital system or the healthcare system, I think there's been a lot of good thinking over the last many years, especially from community partners around the sort of upstream interventions and supports that we need in place to keep people out of the hospital or to be admitted to hospital for reasons, as you mentioned in the articles with colleagues, Dr. Varner and Lopakis, about social admissions.
What is a social admission? Can I just interrupt?
Yeah. So a social admission, again, I think refers to people who may need to be in the hospital because they have such a horrible social condition, whether it's without housing, whether they don't have access to the food security, where there would be real concerns about discharging someone from the hospital or leaving the emergency department because the social conditions would be so challenging. And so I think that's really that shift in focus, is to not put the failure on the individual, which is, they haven't done enough, so they're going to be admitted, but the system has failed them. And then it creates even more pressure in the system when you have, in Canada, and especially in Ontario, about 107, 110% hospital bed occupancy daily. So there's a very tight pressures on hospital staff trying to work in the emergency department, in the hospital ward with very limited beds. And what I think we've done for far too long is shift that onus to patients. And I've started to call people bed blockers as an example. Nobody wants to block a bed or languish in a bed. They want to be able to be at home or have access to housing, have access to nutritious food to stay out of acute care facilities. But I think this is really the push of social medicine, is to rethink even the vernacular to the way that we help and support people when it comes to some of the most marginalized patients in our healthcare system.
I'm interested to know the FoodRx program integrates food prescriptions into healthcare delivery, which I think is super, it's a super cool connection. What have been the key successes and challenges of this initiative? And how would you envision its scalability?
I think what we're starting to see, one, we need more partnerships like this that have not happened historically between real expertise around food security, a community food access outside of the hospital, with hospital networks or even primary care networks to really try to address this major issue. And some people might argue, well, why? Is food security in the lane of healthcare institutions? And there's a lot of really good evidence and data that people who are food insecure have 2 to 3 times higher healthcare costs. They're 2 to 4 times more likely to be in the emergency department or hospital ward, like we talked about. And ultimately, just from a human dignity perspective, have far worse experiences and health outcomes, which is why I really believe this matters and why we should care, but we shouldn't do it alone. My argument is we need to do it in partnership more than any prescription. Or you need a prescription and partnership, I would argue, to really get at this root cause, or at least be able to help remedy the situation as best as we can. So the partnership with Food Share Toronto was really early in the pandemic. I think we were learning a lot on the fly about how you best get the good food boxes to people, the kind of supports that need to be there, the cultural supports around what this can look like for people preparing their own meals, but also about feeling connected, that a food coordinator was checking in on them. And we all know how important loneliness is and isolation is as a social determinant of health. So I think we learned a lot about how the human connection in combination with access to healthy food and nutritious food is really crucial. And I think on scale, there are a lot of opportunities. I think there's been many efforts to try to prescribe food across the country. And I think ultimately, which we'll get to a little bit later, I think we need to address the pathologies of poverty. Food insecurity is really an issue of income and poverty. But I think, the argument again that I've been making is, well, what would you have us do in the healthcare system? I've never wanted to prescribe housing or food when I was a medical student, but how many times can you see people come in and out of the emergency department or come through the hospital system and only offer a Band-Aid solution? So this is a more upstream sort of help and support, but it does not address the root cause. But I think we're having to deal with food insecurity far too much downstream, where much of the damage or detriment is already taking place.
So then my follow-up question to that would be, what policy reforms, what do you see at the top needing to be done in order to create lasting change?
I think we really need to be serious about the income supports that people require. I mean, we've not seen increases in social assistance rates like ODSP, where we are here in Toronto and Ontario. I think those are realities of where people need better income support to be able to afford nutritious food, to be able to afford food, period, given the cost of living crisis that is affecting, every segment of the population, but disproportionately people living in low income or people with disabilities. I think there needs to be, we've seen some good evaluations of how helpful the Canadian Child Benefit has been for families. There are some strong demonstrations of that helping address some of the food insecurity challenges and poverty challenges that have been in place. So I think really doubling down on those efforts where we need to see every level of government see this as a focus. And again, we can't solve for this in the hospital healthcare system alone. We need really these sort of investments from government to have an upstream solution to what we're grappling with in the clinical realms.
Absolutely. So with the FoodRx program, Dr. Boozary, you have any data to say what happened, how it worked out?
So we have a few publications, Suman, that I think were helpful and happy to share with any listeners. But we've had a publication that was out showing the net impact on mental health and well-being, unsurprisingly, as well as around better management and control of blood pressure and diabetes. So seeing that real causal link again, especially around many chronic disease issues like hypertension, cardiovascular disease, endocrinology, and maybe a little bit surprising for people listening in, but there's a very strong link between mental health and diet, and mental health and access to nutritious food. So we really see it cut across every morbidity, both physical and mental health. But those are some of the priority areas that we saw some improvement in the study and in the evaluation following the FoodRx program launch.
Fantastic. So your next project, and this is, I was following in the news while you were doing this, Dunn House.
Yeah.
Like it's
Yeah.
I was fascinated. Can you tell us a little bit about that project and how you got to it and what were the
And
barriers
how it's going.
and how it's going, of
Yeah.
course.
Yeah. Well, Dunn House again, I think has been a 5-year, labor of love by many, many people. And again, it's been excellent to see the buy-in from the highest levels of University Health Network leadership, from the board and the CEO, from really the early days of conception. The idea that we could take a parking lot, pre-pandemic that was in the West End in Parkdale and donate or lease that land to the city for $1 to unlock some investment from the federal and provincial government to build a 4-story, 51 housing unit complex in partnership now with both the City of Toronto, United Way, and Fred Victor, a housing operator, to care for some of the highest needs patients at UHN. And these are, patients that can make up over 2,000 to 3,000 emergency department visits a year. And again, not because they want to be in the emergency department or people want to be admitted to hospital, but the lack of access is making people sicker. There's nowhere else for people to go on many nights. And so this is where we're trying to interrupt that cycle in a more humane and ostensibly cost-effective way. When you think about the fact that someone staying at the hospital I work at would cost over $30,000 a month versus, $14,000 in the prison system, which is really, as my dear colleague Lana Fredo calls it, a de facto mental health system because people can't access mental health and addiction supports, to around $6,000 in the shelter system to less than $4,000 for supportive housing. So we can't really afford the status quo. And I think to the follow-up question of how it's going, I think we're really starting to see serious changes in people's, health and well-being, even in the last just few months of it being in place, and learning more and more about what other health and social care supports seem to be there. And again, not surprisingly, food is a central piece, how to ensure people have access to food security. For many people, I think it's worth reminding folks that it's been decades since they've been able to have their own place to prepare their own meal. And there's a lot of agency in that. And there's a lot of cultural importance to point around being able to have that kind of autonomy and that kind of agency in your own life that I think many of us, of course, take for granted. And I think that's something where from people having their own bed and bathroom at Dunn House to where there's, it's pet friendly, which we heard from the Lived Experience Advisory Council, being able, I can't don't think you can have housing without it being pet friendly because for many of us, it's really family members. And that is such a vital part for people's own journey. And having access to both primary care and other specialty care right on site, I think we're starting to make some inroads.
So 2 questions. First of all, who is the Dunn in Dunn House? And second of all, is this a pilot program? Are there plans to have more Dunn houses? Are they going to be the same, named after different people? What is the format?
Yeah, so I don't know the etiology of where Dunn comes. It's Dunn Avenue. But it's a great question. I never thought of it that way. I probably should find that out. But that's what we heard from community that people want it named. I mean, initially it was a social medicine housing initiative, but we really want it to feel obviously be named as a house and a home, 51 homes for people. And I think it also needs to be reiterated that the Parkdale community deserves a lot of kudos, that these community leaders, community organizations, neighbors have been pushing for better access to housing for decades. And I think it's really special what's happening at Dunn House, and a huge, huge, huge part of that success or traction is because of the Parkdale community. And Dunn Avenue is a very, central line in that community and neighborhood. And I think Dunn House in that way is really fitting, taking a social medicine approach to housing and health.
It makes so much sense now that you said that it was named after Dunn Avenue. Me, who is from Toronto originally, should have probably put that together. But for people who are not from Toronto,
Good question.
But Dr. Boozary, you said it took around 5 years labor of love. Were there any major roadblocks that you faced when going through this?
Yeah, one of them was, something called a pandemic, which we didn't foresee when this started out from supply chain issues, of course. But, again, in many ways, it sort of, I think, helped galvanize and mobilize why we needed to do this when you look at the data of the fact that people who are unhoused died at a rate of 5 to 10 times of the housed public during COVID. So, I think, and also a very important reminder of what kind of social protections we're talking about, social medicine. It's really about many of the holistic downstream implications from having housing that are in place when we can move initiatives like this. So I think those were some, obstacles that were unanticipated. But, ultimately I have to say, it was 5 years. I want to be fair to the city and all partners. It's not that was set the shovel in the ground, but I think from the idea to the commitment to the ability to mobilize the supports and investment needed during a pandemic, during a supply chain challenge. And I think really where we're hopeful is that Dunn House was cited in the Liberal policy platform as the election took place last week as a model that is of interest for the government to scale. And I really hope that we can see this be scaled across the country in various cities. And to your point, Simon, I hope where we can learn and hopefully not anticipate too many disruptions in trying to do twice as many Dunn Houses, twice as fast.
Yeah.
I can't wait for that.
To that end, what policy reforms do you feel are essential at the provincial or even the national level in order to create that kind of lasting change?
Yeah, I think just ensuring that the supportive housing budgets from a provincial piece are there. We need investments in supportive housing, beyond Dunn House. It's currently not at the level we need. I mean, we need investments in social housing when there's an 8-year wait list to get in to social housing. And so we say homelessness is a terminal condition. It's not sensationalist because many people tragically pass away before their number is called. And I would argue we need to see a serious commitment to the Rapid Housing Initiative. That was a federal program that provided the capital investment in Dunn House. And I think we need to see that rapid approach again, in half as long, 10 times as many across the country, across the city, to really best address the homelessness crisis, which I hope in this conversation is clear is really a health crisis.
Absolutely. I think that is a lot of time people do not understand the link between healthcare versus food care versus homelessness, how closely it linked. In Scarborough, we serve around 8,500 people every week with access to food. And 92% of our clients, they spend more than 75% of their income in housing. So where are they going to buy their food? And it's just one step closer to being homelessness. They're very right at the border.
Yeah. And I mean, that's exactly it. I mean, that's the impossible decision that many of our patients and communities are facing is between paying the rent, paying for medication, or paying for groceries. And which of the three are you willing to forego? And if someone thinks about that, any of those has major implications for their health, whether it's groceries, it's rent, or your medications. And, a lot of times it's people having to forego taking their medications to try to stay housed and to be able to feed their family. And you can't fault them for that. But in medicine, we learn to not write again. The system is failing the patient and not ensuring policies are in place that people can afford the most, vital and fundamental aspects to health that they need. We write patient has been non-adherent with medications. And when really I wish we could write, patient is being exposed to undue risk.
Patient needs more support.
I mean, I think it's the most simple language, and we use, this esoteric framework, I think, to paint over the realities are that these are real social ills and that are driving these terrible, impossible decisions for people when it comes to their health.
And it's a transfer of responsibility, right? What we're trying to do is take the onus off the patient as somebody who is obviously already incredibly compromised and take it back into these systems that might actually stand a chance of being able to do so.
Yeah. And, and I can hear people saying, well, people have to have accountability. And I understand that, but we can't keep stacking the cards against people and then blaming them for bad outcomes, and I totally agree. We need a system that can provide these supports that can actually prioritize people who have higher healthcare needs, that are sicker. We all believe in this promise of Medicare, right? That your access to the system is based on how sick you are, not where you live or how much money you have in your bank account. And so I think it's a brilliant point. How do you extend that from a systems approach to be thinking around how we better support people instead of, chastising them or blaming them, which it totally does not, line up in a positive way for better health outcomes.
No, and I think also from a social justice standpoint, trying to have a little grace and understand that these people are trying to flourish inside of systems that were not set up for them. So they're doing the best they can with the circumstances that they have. And, we need to adjust the system because the people can't do any more adjusting. They've already tried to give up their rent for their medicine, to give up, they're giving up a whole lot. So we need to kind of meet them somewhere a little bit closer.
Absolutely. So Dr. Boozary, you are one of the, and I'm saying one of the few, not that you really, there might be many other doctors out there, but you've been very vocal about the social issues from the time I've known you. For the new young youth who is going into the medical field, what is that one advice that you might have?
Again, all this work is in a continuum, and I think so much of the way I think has been shaped by mentors, from nurses and physicians in practice. So, nothing that I'm saying is altogether new, and I think of Dr. Paul Farmer, who was the chair of social medicine at Harvard University, who passed away far too soon a few years ago, was a dear mentor of mine and shaped a lot of my thinking. And the hope is, to your point about the next generation, I'm actually far more hopeful about this next generation that's, picking up a lot of this work that I think is approaching it and better understanding, I think, some of these connections that we've been talking about, how you stitch together issues around the homelessness crisis to what's happening in climate change, what's happening around issues in terms of poverty, to how we're treating elders, and a lot of the systemic discrimination really driving and shaping health in a profound way that we are grappling with at a clinical level and far too often feeling much more powerless. And so I think, my advice on that would be is to not back away from those challenges. You'll continuously be facing sort of different stages of your career where, there's a gentle nudge and shift away of where the healthcare system does what it needs to do, and be a community system needs to do what it needs to do. And there'll be far more siloing and this feeling that, it's out of your space, it's out of your realm, and it's out of your scope. And I think for whatever feeling of injustice that you've cared about over the last few years, and there's many, especially think about the last 5 years we've seen be illuminated, whether it was the number of deaths of elders in long-term care homes, to the systemic discrimination facing Black and Indigenous peoples in Canada, to refugee and newcomer individual health, to what's playing out now with income inequality and food insecurity, to not let that sense of injustice go or dissipate. And however you can hold on and preserve that feeling to compel you, whatever issue you think speaks most to you, I would not lose sight of that. I would not lose the proximity to that as you go through your training.
I also I come at this from a level of cautious optimism because I feel like social justice as a concept is much more normalized now than it ever has been. I mean, people who are within social justice spaces, when my parents, were sort of in their prime, was a radical notion. Social justice was radicalized, and it was really it was in some cases made unlawful.
Mhm.
And there are kids now, we've normalized this, we've de-weaponized a lot of it. I think social media has helped to flatten those silos, and it's allowed people to have these conversations in much more open spaces across timelines and time zones and countries. And it's opened, I think, the arena for those types of discussions, because this is the world that these people have grown up in. It's not a new concept that's trying to be put on an old system. This is the world in which they exist.
Absolutely.
And so I think it's emboldening them to have conversations about really hard things and helping them to try and come up with solutions. At least I hope, anyway. That's
Good hope.
I mean, at the same time, I just have to give lots of solidarity and kudos to colleagues who are leading equity, diversity, inclusion initiatives in healthcare, because on that front, it's not an easy time, and there are real challenges, as you mentioned, that people are trying to rip away equity work, whether it's from research to implementation, all while the fundamental premise is still there that we need to create fair, more humane health systems. So I think it's definitely more visible. I think in many ways should be, more understandable, but that doesn't mean that the uphill battle is not there for colleagues who take this on, especially in the education space. And I just think, providing that solidarity, but also understanding the work is, of course, far from over, but appreciate the comments.
I'm also interested in the path to creating food prescriptions. I'd like to know sort of how that all came to be and how that's moved the needle, if it has at all, in healthcare delivery.
Yeah, we've seen some evidence from other jurisdictions that have worked, maybe surprisingly. We've talked about this big push against EDI, but one of the many Medicaid systems and health organizations in the United States have actually been at a leading spot of the curve, I would argue, on food as medicine and food prescriptions. So we've seen some really good evidence come out of U.S. healthcare systems and these partnerships with different models and different funding models. But a colleague, Seth Berkowitz, has probably had some of the best evaluation and research in this area, and many other colleagues that have looked at the connection over 10 years ago between the end of the month where food stamps would run out and visits to the emergency department because of low blood sugar. And so there's been some really important work out of the U.S. that we have to acknowledge. And that's why I think the challenge is really on us in Canada. If we really believe we're a fairer society, we're a more humane society, well, we need to see ways. And again, I don't want to give the perception that I think food prescriptions are the sustainable solution. Obviously, I think we need social programs to be in place. We need to address issues around poverty. And I would love to see food prescriptions completely obliterated once we can show, government and funders why this really matters. And those kind of investments can be made upstream. But uh, we also have a lot of privilege working in healthcare and university systems where we say, well, let's wait until we see basic income for all. And that should be what we move towards, not food prescriptions. What I tell you, it's really hard to be a healthcare provider and a healthcare worker and see someone in front of you who is, as you laid out brilliantly, grappling between paying their rent, paying groceries, or renewing their medication. And you tell them, I can't really help you, but let's stay hopeful about basic income for all coming soon. And that's the disconnect between where I think, this work in community, this work in hospital, the really important work that's coming out of universities and research teams, and how can we help bridge some of these solutions till we get to, one that again, I would argue is much more sustainable and is much more important in addressing the root cause of food insecurity.
You're looking at me like I'm supposed to ask the question that I ask all the time.
Yeah, I
'cause it's
know,
my favorite
exactly.
question. I can tell.
I don't know the question is, so I'll wait on bated breath.
I have a couple of questions. First of all, best case scenario, I'm always interested in hearing, because we've been talking about a lot of really heavy concepts throughout this podcast. And I always like to kind of inject a little bit of optimism into this, like what's the best case scenario? And also, what is the question that nobody asks you when you talk about this stuff? Is there a topic? Is there an idea? Is there something that you wish had come up in conversation, or that you had a minute to present that doesn't normally get addressed when you conduct interviews or when you're having conversations?
Wow. Two really good questions. All, packaged in one. So maybe I'll start in your order, about some of the best case scenarios. I mean, I think best case scenario, we kind of talked about it. That we actually don't need social prescriptions. In fact, we actually move away from that. We see the social investments and public spending be there for all people that require uh, better options. And I think that's something when we look at, from childcare to social assistance, which we've talked about, all the way to basic income. And ultimately, really, I mean, to me, the best case scenario is that we deliver on housing for all and housing as a human right. So that to me is the best case scenario. And it's one that I think many of us believe that we can achieve in our lifetime and are dedicated to. And if we don't have that belief, I think the actual worry is that this will actually be far worse than it even is right now, where we've seen some widening disparities, as we've talked a little bit about on your program. So I think that's the best case scenario. And I think it's one that is genuine and one that I think we have to all remain committed to and continue to fight for. And we've seen some pockets of success. So how can we, scale to some better solutions and more fair solutions for people?
Doesn't feel impossible either. It's not like some asinine, hope that is never going to land. At least that's the energy I'm putting out there. That's
I like that. Yeah. I mean, it definitely, you don't want to discount the collective effort that's going to be required and that has happened to date, but definitely one where, we just got to keep going uphill. I think to your second question, around what is a question that people don't really ask or topic, I think probably a little bit around what the toll is on health workers and families and communities and caregivers. I think especially around caregivers, like to me, one, we talked a little bit, there's a lot of moral distress if you're a healthcare worker, you've done all this training, whether it's in nursing and social work and medicine and occupational therapy, and you can't help the person that's in front of you. I think that definitely weighs on you, and it's been happening far too frequently for people. And then more importantly, what that means for the person who has to live that reality and their closest loved ones from a caregiver perspective. And, this seems impossible to try to navigate for the individual. And that same feeling of impossibility and despair, really weighs on caregivers. And I think they continue to be the most undersung, parts that is holding up the healthcare system in whichever way you can feel possible. So I hope we give more and more credit and more focus of how we can support caregivers who are just filling the holes every which way they can with their own bodies and their own health.
yeah, absolutely. One of
Fantastic.
those things that I've been learning through this process is it's this pattern that I'm seeing of the most vital members of our society are the ones that are getting the least amount of protracted support or care themselves. We've devalued farming, and yet farmers feed everybody. Teachers have to pay for their own supplies, but they're educating people. Healthcare workers, frontline workers are literally keeping people alive, and they're the ones that are, they themselves are coming apart. And it all seems a little bit backwards to me. You're the sections of society that should be celebrated and lauded and supported the most because you're all part of the glue that holds all the rest of us together. And you're out there kind of fighting for your own sanity on top of everything else that you have to deal with. And then you're getting up the next day and you're going and doing it all over again. So I guess that's a long-winded way of me saying thank you very much for all of the work
Yep.
that you and your colleagues do on a
Exactly.
daily basis. And that doesn't probably get said to you as much as it should.
Yeah. And then, I have to redouble that to colleagues who are, working at the front line 7 days a week, right, in all parts of the city, all parts of the province that have, relatively far less funding and resources than than we do in various parts of the city. Whether that's in Scarborough, whether that's in parts of the city in the Northwest, where they're having to grapple with that and reconcile these tragic outcomes every day. And I know because we speak daily. Be the first to say all of that though pales in comparison to the realities of what people living in poverty, people with disabilities are having to endure because of these policy failures. So there's this connection, of course, between us. There is this commitment, but ultimately, we know from the data that we are siphoning away life years from people in a really cruel way. And I think that's what we just need to be really clear about, because I think if we don't call it out, people start to normalize and feel like this is just what happens. Yeah, or ignore it or accept it or, try to offer some silence or platitudes. And the realities are we really need better policies.
Yeah.
100%.
Yeah.
So Dr. Boozary, thank you so much for your time. This was fantastic. So much to unpack. And thank you so much for all you do.
Yeah.
It's fascinating. And thanks for finding time. It was a pleasure.
Hope to stay in touch, and thank you so much for thinking of us and our work, and looking forward to continuing the conversation.
Dr. Boozary, a wealth of knowledge.
What an amazing guy.
I know, like a doctor. And this is something that a lot of people ask me, like, why do you have a doctor on your show when you talk of global hunger? And this is exactly why, what we just heard. But this is what is really fascinating for me is the intersection of healthcare, food, housing, and that is all what we saw in Dr. Boozary.
I mean, I think what it does for me anyway is it acutely brings us back to the idea that these are all social justice issues. This is not somebody not trying hard enough to
No.
feed themselves or stay well. These are, as I said in our discussion, people trying to flourish inside of systems that have built to exclude them. And you can't get out of poverty if you're not well. And
Absolutely.
you can't be well if you're hungry.
And we know in North America, especially, food insecurity is not a food issue.
No, and we've said this. I mean, we need a jar and we'll just put $10 in every time we said it.
$10, even a penny, will be rich.
The hunger is a political issue.
It is. And there is a lot of other issues that contribute to
Yeah.
food security. And food insecurity is a byproduct. It's
Yeah.
a byproduct of lack of housing, byproduct of politics,
Yeah.
byproduct of healthcare,
Yes.
to be matter of fact. There's a byproduct of a lot of different things. Transit, you name it, and you got it. Jobs,
Hmm.
employment, everything. So when we're talking of food insecurity, and it's really fascinating because Dr. Boozary's work, especially with the Dunn Avenue and the FoodRx program,
Hmm.
it clearly demonstrates that there is a lot more to food insecurity that we need to unpack, and we need the politicians, the powers, to
Yeah.
actually understand how they're all connected. And Dr. Boozary mentioned recently we have seen some projects where our federal government, our municipal government has stepped up and really understood this encompassing case.
Hmm.
But we just need to see more. It's
Well,
just not enough.
I mean, again, I go back to the same thing. I'm a broken record, particularly somebody who's sort of quote unquote on the outside of all of this. But two things. First of all, there isn't any infrastructure in this country to support any of these programs and policies.
Unfortunately.
So that's a huge problem because you're asking grassroots organizations to move mountains. And these mountains,
Yeah.
have.
We are doing the job of the government.
Yes. That is a huge problem. And also the fact that, that Margaret Mead quote about group of motivated citizens can change the world, right? I mean, here's yet another example of a community-led program where, healthcare professionals have identified a need and they've said, there's a correlation between these two things, and we're going to go through at a grassroots community level and see if we can address those issues in the absence of anybody from
Policies.
saying,
Simple.
hey, I'll come and do this for you.
But you know what, Stacey? I think you're absolutely correct that people can move the mountain, and the healthcare team has done it. But at the end of the day, at what cost?
Well,
And that is
frankly,
something we need to think about.
it's not their job.
No.
It's not their
And-
job to do that. And what they're trying to do is get ahead of this runaway train. And I have a lot of admiration for that. But honestly, this is the problem with expecting teachers to look after kids and having, kids getting fed in schools. It's not the school's job to feed
No.
children. They're not supposed to be addressing those issues. We have a humongous problem that's being spread off into other places that are already under a lot of pressure themselves.
That's it. Like healthcare system is crumbling.
Right.
There's no question about it. If I walk into the emergency room today here in Ontario, I got a 4 or 5 hour wait.
I mean, if you're lucky.
If I'm lucky. But then again, these healthcare staff is going above and beyond to help the people that they don't need to work on housing. They don't need to work on food security. It's somebody else's job to do it.
Yeah.
The same thing goes with nonprofit world. And we are eventually going to crumble.
Yeah.
That it is not. We are working with pennies to a dollar, and we are trying to solve the problem that technically our governments should.
Well, if you're concerned about the cost of these things, I mean, we've talked to several people in the last little while who've said the cost is actually not that big. I mean, Dr. Boozary was saying if you want to stay in a hospital for a month, it's 30 grand.
No.
If you want to live in Dunn
Yeah.
House, it's
Yeah.
4 grand.
Exactly.
So if it's straight up economics, if that's your hang up,
Yeah.
there is no problem. We were talking to Cecilia earlier about what's happening in Brazil. She's like, the turnoff is that people think it's too expensive. She's like, it's not really
No,
that
it's
expensive.
not.
So it's not the money, is what I'm saying.
It is
The money is
outlook.
not the problem.
Money is
It's
not.
outlook, it's political will.
But
it's,
even if you think about just forget food insecurity for a few minutes and just talk of health,
yeah.
like investing in food care versus investing in healthcare.
Well,
It's proactive, reactive,
and it's
and much cheaper.
far less expensive.
Exactly, much cheaper to properly invest in food care than to invest in healthcare.
Yeah.
But it is just the way you look at things. And we are hopefully advocating hard for governments in all levels and all countries to be open and look at it differently.
Yeah.
So that is today's podcast. I hope you enjoyed it, and I'm looking forward to our next conversations.
Mhm.
In the meantime, if you liked it, please subscribe if you haven't yet. Send us your questions, comment, give us your feedback. What do you think?
And also go follow these people with whom we're having these
Yes.
conversations. Go learn more about what Dr. Boozary is doing or any of the other people with whom we're having these conversations because it's
Absolutely.
incredible what they're doing.
And especially Dr. Boozari's work is amazing.
Yeah.
But I'm also going to give a plug to my book.
Yes.
It's the Zero Hunger Project. It's available in any of the stores that you generally buy your books at. Please take a look, and if you can read it, it's going to give you some good solutions that's happening around the world on hunger and some unfortunate stories as well. So follow us, and we'll see you next week.